Good.
Well, first of all, I want to say thank you to these great colleagues who are taking their Saturday night. Some have traveled extensively to get here, even from Brazil. So thank you very much for being here. A true friendship. Thank you. So Erkut, a great fan of LSU, I might imagine, but they didn't even play today, I guess. But Erkut, can you give us your vision of the trial that you'd like to do to make a great impact against the disease?
Absolutely, and Dan, thank you, and wonderful presentation, and thank you all for coming out tonight. But I did want to talk about the fact that there are several exciting new insights into the biology of pancreatic cancer, and that's led to, as Dan has mentioned, several opportunities to help people live longer and treat them more effectively with some of these new therapeutics. We have learned a lot about how pancreatic cancer interacts with our immune system. We know that certain cancers, such as melanoma and kidney cancer and bladder cancer, we consider these as hot tumors in relationship to the immune system. And they are very responsive to therapies that target the immune system to activate it, such as the therapy that President Carter has received for advanced melanoma, that have been led to remarkable treatment and survival for these individuals with these very advanced diseases. Pancreatic cancer, on the other hand, is a cold tumor and does not respond to immunotherapy in the way that these other cancers do. Thankfully, there are several scientists around the world that are working on trying to make these cancers more responsive to immune therapy. One group led by Dr. Ron Levy at Stanford has developed, in essence, a vaccine that can be injected into a tumor that can activate the immune system against the tumor and make that tumor hot. What's really striking, though, is that injecting that one tumor affects all the other tumors around the whole body. And so what becomes a cold tumor to the immune system becomes hot, and especially in combination approaches of stimulating your immune system can make the entire, all the cancer all over the body go away. And so what we'd like to do is to take Dr. Levy's therapy. His targeted agent is called CMP-001, and we want to combine this with immunotherapy that will stimulate your immune system, and to offer this to individuals with refractory pancreatic cancer. So we hope to see the same things that we are seeing with other tumors with advanced melanoma and advanced kidney cancer, translating to the same approach to people with advanced pancreatic cancer. Again, I thank you all for coming out tonight from near and far, and for the support that you've given over the years, for the individuals that we've all taken care of over the years. So thank you again for coming out tonight.
Thank you, Erkut. Thank you, Erkut. Dr. Hidalgo is next. And Dr. Hidalgo, could you give us your vision of a very unique way to help patients with pancreas cancer, a trial you'd like to do?
Thank you very much, and good evening. It's really a pleasure to be here. Thank you, Dan, for the invitation, and Roger, and to the Seena Magowitz Foundation for hosting this event. It has been really illuminating, your talk and the presentations and what we have heard tonight. I want to tell you about a project that we have been working in the laboratory now for a couple of years, and that we think is ready to advance to the clinic. You heard that one of the areas of major interest in cancer treatment is immunotherapy. It's using the own immune system from the patient to treat the cancer. That has been effective in some diseases, but not yet in pancreatic cancer. There are multiple reasons. One of them, we heard that the T cells, the lymphocytes, the executor of the immune system don't get into the tumor. But other reason is that the pancreas cancer is not alone in the body. It's surrounded by what we call the stroma. And that stroma produces a lot of substances, a lot of proteins, a lot of signals that keeps the immune system sort of dormant. It doesn't see the tumor. It doesn't recognize it. So a number of years ago, together with my colleague Senthil Muthuswamy at Harvard, when I was in Boston, we developed a methodology called organoids. That consists on taking a piece of the patient's own cancer and growing it outside the body, growing it in vitro in a laboratory three-dimensional system. By that, what you achieve are several things, but one of them is that A, you get a tumor that is genetically very similar or almost identical to the tumor in the patient, but B, and very important, is not influenced by these external factors. It's sort of naked. It's alone, it's not protected. When we take blood from the same patient, just from your vein, and culture together with that tumor, that immune system that was unable to see the tumor, it was hiding, now all of a sudden can see it. And these lymphocytes, after staying 2 weeks, co-culture with the tumor with several growth factors and several ingredients, they start recognizing it. And of course, because it's foreign, is ill, is not the own body that our immune system has been taught not to kill, they start killing it. And actually, when they kill it, they're pretty effective in killing it, to the point that if we take those T cells that we call OP T cells, organoid prime T cells, and put it together in another organoid from the same patient, they kill it in 48, 72 hours very effectively. So we have done in vitro studies in the laboratory. We have done in vivo studies using this system, sort of mimicking a clinical trial in mice, and now we are ready to move this forward to the clinic. The next step will be anytime that you do a sort of a very complicated treatment like this, you need to spend a lot of time in the manufacture. So we need to create what we call the GMP, the manufacture in quality conditions to administer to the patient, and then to do sort of a pilot clinical trial to prove that it's safe. But eventually we envision that this will be a treatment that, while the patient is getting these Seena regimens that are so effective, 90% response rate, 100% response rate, this can be done sort of in the back office, and by the time the patient is done with the chemo, you could do similar to a bone marrow transplant, but lighter, and that could perhaps help the tumor for coming back and will completely eradicate any cell that may be lagging behind. So that's the project we've been working in, and it's been very, very fun and very interesting to discuss this with Dan and the team, and we're ready to go. And thank you very much for listening. Thank you very much for your support and for everything that you do. Thank you.
Thank you, Manuel. And as we're speaking about something maybe even called STING, Dr. Sunil Sharma has a very unique clinical trial that he would like to describe, and a little background on that. Sunil?
Yeah, thank you again. As everybody already said, thanks everyone for being here, and thanks Dan for. I don't know that people know, but Manuel and I were Dan's fellows 25 years ago, almost.
He's younger than us,
yeah, we were.
That long ago.
So, thanks for your inspiration over the years, and thanks anyways for recruiting me to come back here to work with you. We have a long history now, at least 15 years of developing new treatments for different kinds of cancers. And so the one that I'm going to talk about today is really exciting because, like was mentioned before, pancreatic cancer doesn't really respond to the normal immune therapies. And part of it is, like Dr. Borazanci mentioned, it's a kind of what we call a cold tumor. It's not very inflamed, so it's really difficult for T cells of any kind to actually penetrate in there. There really aren't that many T cells that are sort of our immune cells that actually kill cancer in the vicinity of the tumor. So it's very difficult to actually get them in there. You guys might have heard of a very novel kind of treatment called CAR T cells that are sort of these supercharged T cells that have actually cured some leukemias, but haven't really worked in pancreatic cancer. So one of the things that we've developed over the last 4 years is kind of a set of chemicals or drugs that actually make the pancreatic cancer from a cold tumor to a hot tumor. And these go after a protein called STING, like the bee sting, and it sort of activates it. And the treatment that we have developed in the lab and is ready to go into the clinic is actually taken orally as a pill, not intratumorally, because we don't think that giving it into the tumor actually, you can kind of activate or inflame that one area, but as we all know, pancreatic cancer sort of spread throughout the body, so you want to sort of inflame it throughout the body. And when we combine that with either CAR T cells, which are these supercharged T cells, or theoretically you could combine it with what Manny was talking about, then you can actually get the T cells to penetrate better into those cancer areas. So this is really an exciting time to actually make our immune system work better against pancreatic cancer. You heard of several different approaches. We don't quite know which one would win, but we think that if we sort of as a group make a concerted effort to try some of these new immune therapies and make them work, it would be a significant advance above and beyond all the stuff that's already been done by Dr. Von Hoff's team as well as the Seena Magowitz Foundation. So they would almost be the 5.0 would be the 2.0 of a new set of treatments that are completely different from the ones that we've done, which have actually improved survival of patients. So I think we're all committed here to making these kinds of treatments work. And again, thank you so much, everyone, Roger, for having this great event, everyone here who supported it, all the patients and their families, and of course, Dan for spearheading this effort for such a long time. And we're very grateful. Thank you.
Thank you, Sunil. Well, last but not least, as a doc, you always give the best compliment to say, if I really had to have surgery, then this next man would be the person who would do it. Dr. Doug Evans has been a great pioneer. He was head of surgery at MD Anderson and pancreas cancer. And Doug, we're going to give you the final word of your vision of how to tackle this disease with a specific protocol you're working on.
Thanks, Dan, very much. I have to take 30 seconds, if it's okay, to just tell you I have the greatest job in the world. And this is, I think, maybe my 4th or 5th weekend thinking about pancreas cancer in some kind of an event, whether it be a scientific research retreat or a wonderful event like this. And I have to tell you, in order to maybe loosen up the audience a little bit for the auction and other things to come, last weekend I was at Swan's Pumpkin Farm, which is the largest pumpkin farm in the Midwest, huge. And Ken Swan, who owns it, is a pancreatic cancer survivor, and he donates a tremendous amount of proceeds. Every year he has rounding up for pancreatic cancer research. It's incredible. So I was there last Saturday afternoon. It was a beautiful Wisconsin fall day. There must have been over 3,000 people there at this pumpkin farm. And so there are only 2 checkout lines, and I had my pumpkins. And the lines went almost to the back of this room. And I got a page that there was a little issue at the hospital and one of my partners needed a hand. So I was really in a sticky situation. I mean, what am I going to do? I can't leave the pumpkins there. I can't not pay for them. So I grabbed one. This is basically run by all these high school students. So I grabbed this woman who looked like she was sort of in charge, and I said, I'm Ken's doctor. She said, oh, Dr. Evans, I know who you are. I said, well, I really need to get back to the hospital. Can I just give you some money for my pumpkins? And she said, well, I can't really estimate the cost of your pumpkins too well. She said, now, I'm going to be off if I try to estimate your pumpkins. And now this is a junior in high school. But if I estimate all the pumpkins ahead of you, I will be fairly close. So just give me your credit card, and we're going to comp all the pumpkins in the line ahead of you. And she actually did. Yeah. So I was about $600 lighter after that trip. But yeah, junior in high school.
Good job.
Anyway, as Dan mentioned, we've been interested in curing patients with localized pancreas cancer and have spent really decades trying to do that. Right now, for patients who have surgery, the cure rate is approaching 40%, which is incredible. I mean, a decade or 2 ago, you never would have thought that was possible. And what we have been interested in is novel ways to combine chemotherapy, radiation, and surgery in the most optimal way that results in the best cure. And we were really struck by a trial Dan did years ago called the Bisgrove trial, supported by the Bisgroves, where he looked at the expression of genes or gene expression in the tumor as a guide to deliver chemotherapy. And we said, why can't we do this in patients with localized pancreas cancer? Do a needle biopsy, look at gene expression, and then give, if you will, personalized treatment to those patients. So we invited Dan to Wisconsin. He may or may not remember this. He probably has PTSD from this event. But we put him in his very close friend, Paul Rich. We met in his office, and we brainstormed about this. And Dan was saying, well, you can't really do this off of just a needle biopsy, and had a few other concerns. How are you going to turn this around in just 4 or 5 days? And so after a couple hours, it was clear that Dr. von Hoff, had sort of had enough. And I said, Dan, we're not leaving this room until we get this sorted out. I mean, we are getting, so fast forward now about 7 years, we did a trial that involved all of those technologies. We figured all that out, enrolled 130 patients. It's now been published. What we would like to do is, with one of our collaborators at the University of North Carolina, who has developed some fascinating RNA technology to look at the molecular fingerprint of pancreas cancer, incorporate this into our backbone of a needle biopsy of a fast turnaround within 3 or 4 days to deliver truly personalized medicine, while at the same time do more in-depth analysis of gene expression on those tumors, so that if things don't get dramatically better in the first 2 months of treatment, to change treatment, to really try to move the needle even further. And I think the technology that we've developed over the last 5 or 6 years is tremendous, and fortunately, based upon a lot of what we've learned from TGen and your illustrious host here tonight, I think we can definitely do this. So it's a real treat to be here. Thank you all so much.
Thank you, Doug. Well, I'll summarize. You can see how intelligent and how lucky we are to have people like this working on disease. I showed a picture of many others, but these 4 ideas are just really outstanding, and we really think it can make a big impact against this disease. I thank you for coming and being great colleagues and all you do for patients. Thank you.
Thank you.
Thanks. Thank you.
Thanks so much. Thanks.
Great job.
Thank you.